day, dear students. Our topic for today is management of outpatient with chronic liver disease or liver diseases in polyclinic. It is interesting that in polyclinic may be absolutely different patient with absolutely different liver disease. And it may include different pathologies based on classification of World Health Organization number 10, which is used in our country now. Liver disease, chronic diffuse disease of liver divided to alcoholic liver disease, including alcoholic hepatitis and alcoholic cirrhosis. Toxic liver disease, including toxic liver disease with chronic hepatitis and cirrhosis. Fibrosis and cirrhosis, including fibrosis of the liver, biliary, primary and secondary cirrhosis, macronodular, postnecrotic, micronodular, portal, or Lionx and mixed cirrhosis. And also other disease of the liver, including cardiac cirrhosis. In other part of this classification are included chronic hepatitis due to different viral infection, but they are under infectious disease in this classification. But of course, patients with chronic viral hepatitis are present in polyclinic. Morphological classification of the disease of the liver based on findings of needle biopsy of the liver includes two main types, hepatitis and cirrhosis. Now, acute and chronic hepatitis and cirrhosis not is always chronic. Main causes of hepatitis are viruses, drug-induced, and toxic, and cirrhosis may be alcoholic, postnecrotic, biliary, and others. Really, both these classifications are completely useful, but there are many other more new diseases which not discussed in this relatively old classification. That's why I want to pay your attention to some of them which are commonly spread in the community. One of them is steatohepatitis or fatty liver disease, which characterized by inflammation of the liver with concurrent fat accumulation in the liver. Classically seen in alcoholic as part of alcoholic liver disease, steatohepatitis is also frequently found in people with diabetes and obesity. When not associated with excessive alcohol intake, it is referred to as non-alcoholic steatohepatitis, NASH, and is the progressive form of the relatively benign non-alcoholic fatty liver disease. In effect, around 30% of population, at least in Western societies. Steatohepatitis of either cause may progress to cirrhosis, and NASH is now believed to be cause of unexplained cirrhosis. So I want to tell again that this problem is very common because obesity is very common in population nowadays, and fatty liver disease develops in many persons, but not always it accompanied by inflammation. Mostly it is benign, but in some persons it accompanied by inflammation. In this case, it called steatohepatitis. Hepatitis means inflammatory liver disease, and steatohepatitis in adult person is very common, and it affect liver, affect its work. It is risk factors for cirrhosis and for liver carcinoma. And also, it is a risk factor for progression of ischemic heart disease, cardiovascular disease, and also diabetes mellitus and NASH. Both may affect each other, and if both are simultaneously, more severe clinical picture develops. Very commonly, NASH develops in patients with diabetes mellitus and cardiovascular problems. Another disease which I want to mention you about, and which one we didn't discuss in previous lectures, are fortunately not too common, but you shouldn't forget about it. Uh, Liver problem is not only parenchyma problem. Maybe serious problem in the liver due to bile duct problems, and it include primary sclerosing cholangitis, PSC, and primary biliary cholangitis, PBC. Primary sclerosing cholangitis is a long-term progressive disease of the liver and gallbladder characterized by inflammation and scarring of the bile ducts. The bile duct scarring which occur in PSC narrows the duct of the biliary tree and impedes the flow of bile to the intestines. Eventually, it can lead to cirrhosis of the liver and liver failure. Primary biliary cholangitis, PBC, previously known as primary biliary cirrhosis, is an autoimmune disease of the liver. It results from a slow, progressive destruction of the small bile ducts of the liver, causing bile and other toxins to build up in the liver, a condition called cholestasis. Further slow damage of the liver tissue can lead to scarring, fibrosis, and eventually cirrhosis. Uh, so both these diseases affect biliary tree, but PSC mostly affect large bile duct, and PBC mostly affect small bile ducts of the liver. PSC mostly affect men. PBC mostly affect women. But both of them um, is poor, has no specific method of treatment, and in time, both of them progress to cirrhosis. So we have to do diagnosis as early as possible for prophylaxis of fast progression of this disease. How does it look like primary sclerosing cholangitis? In autopsy, you see large bile duct with thick walls, and in this case it is more difficult to pass the bile through these ducts. Bile stagnation will lead to damage of hepatocyte, its death, and formation of cirrhosis. And now let us go to clinical picture in total for chronic hepatitis. In general, there are no specific features of chronic hepatitis. That's why diagnosis is very difficult to do, and even more difficult to think uh, about about fatty liver disease. For both situations, best diagnostic method is liver biopsy, which shows us damage of liver cells even in case when patient is asymptomatic, especially if he suffer from steatohepatitis. His liver already is affected, but symptoms are absent. In more severe stage of steatohepatitis or other types of hepatitis, for example, chronic viral hepatitis, will be non-specific symptoms. Weakness, maybe aggression without any etiologic factors. Patient is feel sick but don't know why he is sick. He has no pain anywhere as a rule. Sometimes for the more simple for diagnosis in some patient, if he has discomfort in the abdominal, mostly heaviness in the upper subcostal region. Also, in case of bile stagnation in the liver, may be pruritus, but it is not necessary. More specific and more easy for diagnosis if changes in color of the skin and change in the color of the urine or stool, but it is not always present. These symptoms, jaundice, is present mostly in case of acute hepatitis, but in case of chronic hepatitis, it's not obligatory. If present, it always helps for the diagnosis, but it means that very high bilirubin, total bilirubin level present in this patient, and more severe situation develops. Now let us go to cirrhosis, which also can be seen in outpatient. Cirrhosis is end stage of many different liver disease. That's why I give this list of causes for cirrhosis to show you how many different liver pathologies may be seen in outpatient and inpatient also, but our topic is outpatient with liver disease. And all of these disease may progress and lead to cirrhosis. What are main causes for cirrhosis? Most common are alcoholic liver disease and non-alcoholic steatohepatitis. They are very common in population, in adult population, but fortunately both of them have benign clinical course with slow progression as a rule. Next common causes are chronic viral hepatitis, mostly C and B viral hepatitis. Other causes are more rare. Can be autoimmune hepatitis, primary sclerosing cholangitis, which I told you about, primary biliary cholangitis, also hereditary disease, which are mostly develops from the childhood, and when patient come to you, if you are doctors for adult persons, this diagnosis already present. It can be hereditary hemochromatosis, Wilson's diseases, alpha-1 antitrypsin deficiency, congestive hepatopathy, and also candid, you shouldn't forget about hepatotoxic drugs or toxins. So if you see patient in a polyclinic, you see patient who comes first time, second time without diagnosis, and also you can follow patient with already with diagnoses which are already present. More difficult, of course, to make initial diagnosis. And if you see that patient has some liver problem, but after initial investigation, there are no specific reasons, no obvious cause for liver disease, you shouldn't always forget about hepatotoxic drugs or toxins. Even in the initial discussion, you have to ask patient which drugs he used. Many drugs may be hepatotoxic, and they are not so commonly hepatotoxic, but in some specific population with genetic predisposition, each drug can lead to liver damage. So don't forget about it. And also occupational hazards which include different toxins, may affect liver. So you have carefully to take patient's anamnesis and ask him about different drugs and toxins which may affect liver and lead to his symptoms. Clinical features of cirrhosis. In case of cirrhosis, clinical features are more pronounced compared with hepatitis and more specific for liver. And most pronounced may be symptoms of portal hypertension, which include ascites, varices, and varicose bleeding-like complication, and splenomegaly. The most obvious feature is liver cirrhosis and ascites, enlargement of the abdomen, which is visible when you see patient if ascites is large. Next group of symptoms include decreased hepatic synthetic function, which can cause coagulopathy. Patient is predisposed to long-lasting bleeding, ascites and swelling of the ankles in hypoalbuminemia. Ascites has few reasons to develop. First of all, portal hypertension. Next one, hypoproteinemia. Decrease in cortex pressure also lead to ascites and uh, swelling of the ankles. Decreased detoxification capabilities of the liver can lead to hepatic encephalopathy. Patient cannot sleep properly at the initial stage. He sleep at daytime and not sleep at night. He forgets a lot. He is not able to remember something, and in progression, he develops more significant features, and at the end stage, it may be hepatic coma. Decreased hepatic synthetic function, it is bleeding, hyperalbuminemia, ascites, and swelling of the ankles. Encephalopathia, day-night reversibility, tremor, dysarthrias, delirium, and coma. Also may be jaundice, dark urine, and uncolorated stool. What is it? Portal hypertension. In case of liver cirrhosis, more difficult for blood to pass through liver with big fibrotic area and change in liver architecture. In this case, you may see more higher pressure in portal vein, which collected blood from the organs of abdomen, first of all spleen and small and large intestine. In this case, more difficult for blood to pass through the liver. In this case, maybe accumulation of the fluid in the abdominal cavity, which will lead to enlargement of the abdomen. Also, it can lead to varices formation. First of all, varices on the abdominal surface, like here. Also can be varices in the esophageal and also in the rectum. In all parts where there are anastomosis of vena cava inferior and vena porta will be hypertension in the veins due to portal hypertension and enlargement of the vein, which leads to varices formation. Can be edema on the leg and maybe other symptoms also like gynecomastia in male persons. Now, most pronounced, most obvious clinical picture of ascites, of liver cirrhosis and portal hypertension is ascites. Here is third grade ascites. When I developed you a lecture about liver cirrhosis, I told you that maybe 3 grades of ascites. Mild, which is not visible and not palpable as a rule and mostly reveals by ultrasound examination of abdominal. Uh, moderate, which may be palpated and is visible, and large or gross ascites like you see here, which is absolutely obvious and lead to significant pressure to all abdominal organs and its insufficiency. Also may be pulmonary erythema, telangiectasias, and other clinical symptoms of ascites are less obvious. What are complications of cirrhosis? We already talked about ascites. It is clinical feature of cirrhosis, and also it is under complication of cirrhosis. Bleeding, varices present in three main places, but more dangerous are varices in the esophagus, and bleeding may be from varicose veins of the esophagus, stomach, or from hemorrhoidal veins. More commonly and more significant bleeding from the esophagus. In case of severe encephalopathy, may develop hepatic coma. One of the dangerous complications of liver cirrhosis is liver cancer, and maybe due to portal hypertension, maybe more rare, but also dangerous complication, which call thrombosis of portal vein. Now, here is liver cancer, hepatocellular carcinoma. Dangerous complication which commonly lead to death if not diagnosed in time when present metastasis, when carcinoma is large like here in this picture. So we have to check alpha fetoprotein in patient with chronic liver disease, in outpatient with chronic liver disease, once or twice in a year, depends on clinical symptoms, for early diagnosis of this severe complication of chronic liver disease. Also, for early diagnostic of this severe complication, patients with chronic liver disease have to undergo ultrasound of the organs of abdominal cavity each year or twice in a year. How to confirm diagnosis? You see, especially for hepatitis, clinical features are non-specific and more difficult, and it is as a rule difficult to make proper diagnosis. So you have to do analysis. First of all, laboratory analysis for proper diagnosis. First of all, we have to check function of liver cells. Its damage will lead to cytolytic syndrome. Destruction of hepatocytes are accompanied by increase in plasma concentration of intracellular enzymes ALT and AST. More specific for liver damage is ALT elevation. It's as a rule elevated more high than AST. But in case of significant cirrhosis, may be vice versa, may be AST more high than ALT. Cholestatic syndrome. Cholestatic syndrome mostly develops in patients with biliary duct problems, and it's characterized by yellow color of the skin, and in analysis it's characterized by elevation of alkaline phosphatase, gamma glutamine transpeptidase, direct bilirubin, and also cholesterol. Because hepatitis is inflammation, so it may be signs of mesenchymal inflammatory syndrome, which characterized by increased levels of gamma globulins, immunoglobulins, and C-reactive protein in serum. Syndrome of hepatic insufficiency. Many proteins are synthesis of many proteins present in the liver. If present in liver insufficiency, it can lead to hypoalbuminemia, decreased level of prothrombin and fibrinogen, and also to hypercholesterolemia because cholesterol in the liver transformed to the bile and excreted in the intestine. So, if hepatic cells don't work properly, will be a predisposition of patient to low oncotic pressure due to hypoalbuminemia and edema, decreased level of prothrombin and fibrinogen, which lead to significant bleeding, and also to hypercholesterolemia, which is a risk factors of ischemic heart disease. Uh, Portal hypertension will lead to increase to higher pressure in the spleen, which may cause hypersplenism, which can lead to pancytopenia, uh, anemia, thrombocytopenia, and leukopenia in advanced stage of liver cirrhosis. For specific diagnosis, which all previous uh, analyses are not typical for specific disease. They all are features of liver cells damage. What caused liver cell damage? We don't know, but for proper treatment, better to know etiology of hepatitis. So we can do etiological diagnosis, which include serologic tests. It is helpful for many different diseases. First of all, for viral hepatitis. Indicators of hepatitis C viruses, most common genotypes 1b, 3a, and 4, which are more commonly spread in population, are antibodies against HCV, anti-HCV, or components of virus HCV RNA. Indicators of hepatitis B infection are viral antigens, HBS antigen, HBe antigen, antiviral antibodies, anti-HBS, anti-HBe, anti-HBC, immunoglobulin M and G, and anti-HBV DNA. So there are many serological markers of viruses for specific diagnostic. Also, serologic immune markers present in the autoimmune hepatitis, and they include hypergammaglobulinemia, increased ESR, anti-nuclear antibodies, uh, anti-actin antibodies, and antibodies against liver and kidney microsomes. More specific are anti-nuclear antibodies. I told you that primary biliary cholangitis is not so common but chronic and progressive disease which include autoimmune component. So for its diagnosis, you have to use also different serological tests. More specific for primary biliary cholangitis, increased level of antimitochondrial antibodies and so-called anti-GP210 and anti-SP100. Other additional antibodies can be anti-NP62, anti-centromere antibodies, anti-nuclear antibodies, and features of cholestatic syndrome, increased level of ALP, gamma-glutamyl transferase, and bilirubin level. Except laboratory studies are very important in diagnosis of liver disease, in diagnosis and differential diagnosis of liver disease are imaging studies. Most common nowadays and available and not expensive is ultrasound. Ultrasound is helpful in ruling out biliary obstruction or to assess for subclinical ascites and dyskinesia of bile ducts. Biliary obstruction, very clearly seen in ultrasound if present obstruction of uh, large bile ducts. If present bile stones, for example, very clearly seen in ultrasound. And I told you that first stage of ascites, mild ascites, is not visible in general examination, but ultrasonography helps us to see fluid in abdominal cavity in early stages of ascites. And ultrasonography informs the physician about the condition of the portal vessels also. Extension of the lumen of portal and spleen veins, which are typical for portal hypertension. In cirrhosis, there is also diffuse consolidation of the liver with nodules 6-7 mm and irregular surface, hepata and splenomegaly. So ultrasonography shows more obvious changes in case of bile obstruction, in case of liver cirrhosis and portal hypertension, and less obvious, less specific change we can see in case of hepatitis. For example, in case of fatty liver disease. You see here two examples uh, of ultrasound examination of the liver. From the right side of us, we can see non-alcoholic steatohepatitis, which characterized by increased density of the liver and not so clearly seen bile ducts compared with normal liver. But these changes are not too much obvious. Now, many ultrasound specialists give this diagnosis to many persons with obesity, but really for non-alcoholic steatohepatitis, to confirm inflammatory change, we have to do needle biopsy. In real life, for our patient, we don't do it as a rule because they are asymptomatic and never agree for invisible method like biopsy. More obvious change in the liver present in case of liver cirrhosis, which you see in picture from the left of you. You see there are non-homogeneous structure of the liver with field of fibrosis, with nodules, irregular fibrotic area, and change in liver architectonic, and liver becomes smaller and more hard. Liver cirrhosis also will be enlargement of diameter of portal vein and other size of portal hypertension. For liver cirrhosis, ultrasound examination is more specific. But for all patients, later we'll discuss which obligatory method we have to use in outpatient. For all patients with suspected liver disease, ultrasonography of the liver and other organs of abdominal cavity is recommended. More sensitive imaging studies include CT scanning and MRI. CT scanning is necessary to define the character of focal changes in the liver parenchyma if malignant nodules are suspected. You saw previously, I show you again, yes. You saw previously, in case of liver cirrhosis, there are some area with other color compared with surrounding tissue. Mostly it is fibrotic tissue and not malignant tissue, but can be malignancy. more sensitive to see malignancy is CT scanning because it enlarges liver, enlarges the image of the liver more, and it is more sensitive to see small changes in the liver architecture. Also can be used CT scanning with intravenous contrast or MRI. They may be indicated in certain cases to evaluate patient for collateral vessels with intravenous contrast, for example, space-occupying lesions of the liver, or concomitant disease of the pancreas and other organs, or complications, for example, of liver cirrhosis, for example, like varices in the esophageal veins. Here you see in CT regenerative nodules in patient with cirrhosis. You see a row here which shows you regenerative nodules. We need, of course, biopsy to check is it malignant or not. Also, in this CT, you can see that present cirrhosis and ascites. Liver is small in size. It has its surface has wave form due to regenerative nodules, and in the abdominal cavity you may see fluid which has dark color. Here you can see by CT varices and within esophageal walls. It's CT scan, of course, not the method of choice to see varices, esophageal varices. We have another method which we'll discuss in a few minutes, but CT can reveal this problem also in patient with liver cirrhosis. MRI is maybe one of the most expensive and most advanced methods for diagnosis of diffuse liver disease. For example, steatohepatitis. If present small amount uh, of fatty cells in the liver, it is not so bad. It is normal situation. If lot of fat cells, it is more dangerous, may lead to liver dysfunction, to inflammation, and in some persons with genetic predisposition, it can lead to transformation of steatohepatitis even to liver cirrhosis. So, present new method for the diagnosis of the level of fatty cells in the liver. It's called proton density fat fraction. You can see from the left to the right a more white color of the liver. It means that there are more fatty cells. In first picture, only 2% of fatty cells. In second, 11, third, 20%, and fourth, 30% of fatty cells. So with this method, we can check in patients with obesity, metabolic syndrome, how many fatty cells are in the liver and how and check prognosis of the liver. Will liver fatty cells lead to more severe complication or it will not? Does this patient need treatment or he doesn't? But it is not commonly present, this method, and is expensive now. Other imaging studies include radionuclide liver scanning with colloid gold or technetium. This method is relatively old, and in cirrhosis it reflects diffuse irregular distribution of the radionuclide in the liver and scanning spleen, which actively absorbs radiotraces, more than 15% of the dose introduced. So in this case, we can see the spleen For example, you can see it here. In case of cirrhosis, spleen normally is not visible if portal hypertension is absent. And you see a small cirrhotic liver, which size is very closely to size of the spleen. In normal situations, spleen is smaller and smaller than liver. Elastography is one of the new methods of imaging studies. Elastography is a medical imaging modality that maps the elastic properties and stiffness of soft tissue. Transient elastography, known by the brand name FibraScan, is non-invasive test to quantify liver fibrosis. It also detects and quantifies steatosis. So, main problem in patient with liver disease, with chronic liver disease, is stage of the liver disease. Does chronic liver inflammation, chronic hepatitis already lead to cirrhosis or not? Stage of liver tissue damage. In case of transient elastography, we can check density of liver tissue. If there are a lot of fibrotic area, liver became more stiff, has more high density. In this case, transducer, which sends wave through the patient's abdomen, see its reflection more fastly. If liver has high density, more fast reflection. If low density, more slowly reflection. And this change in reflection of the waves is mapping by the color. In case of red color, means that high density of the liver tissue. In, uh, in this case, we are thinking about high probability of transformation of chronic hepatitis to liver cirrhosis. Liver stiffness, more red, more probability of liver cirrhosis for in case of chronic liver disease. All of them can transform to cirrhosis, but fortunately not in all patients. May transform, but and may not. Depends on patient's treatment, depends on patient complaints to treatment, depends on hereditary predisposition to liver damage. And all of them we can check by elastography. Transient elastography, it's not ultrasound, but ultrasound also can in some ultrasounds may present some transducer which may check elastography by pressing to the liver, and in this case we can get such picture. From the right part you can see uncolorated picture, it's usual ultrasound. In the left part you see colorated picture which shows us more clearly fibrotic area and damage of the liver tissue. You see, red color is fibrotic area, and as a rule, it's placed at the same time where in usual ultrasound we see more white area. So we can suspect fibrosis in uncolorated image, but colorated image helps us to calculate how much fibrotic area present here and to see it more obviously. And one of the important methods in patients with liver cirrhosis is the factor gastroduodenoscopy. This method is very important to check to assess risk of varicose bleeding. But cell bleeding may be large and may lead to sudden death in patient with liver cirrhosis, even if patient is hospitalized. Significant bleeding may lead to really very fast death if it is a bad lot of viruses damage and significant bleeding. So we have to do esophageal gastric duodenoscopy. First of all, for diagnosis, it is best method for diagnosis of viruses in the esophagus. And also, in case of bleeding, it can be used for treatment. Because they are deemed high risk patients with liver cirrhosis in whom decompensation develops should have esophageal gastric duodenoscopy AEGD performed to screen for gastroesophageal viruses unless previously diagnosed and treated. So if it is used for diagnosis first time and it is used for control of the for the size of these viruses and its predisposition to bleeding. If patient develops more severe clinical symptoms of cirrhosis, if ascites, for example, progress and weakness progress, in this case, patient have to be sent to EGD. If EGD is performed, the size and presence of red whale marks should be reported. I already told you in previous lectures what is red whale marks. It is marks for which looks like red lines on the surface of viruses, and it indicates that the wall of these viruses is thin, and these viruses are predisposed to bleeding. In patients without viruses on screening EGD, in whom the etiological factor persists and or stage of decompensation continues, screening EGD should be repeated every year for early diagnosis of viruses progression and proper treatment of this patient. How does it look like viruses in esophageal gastroscopy? You see big veins in the esophagus. Here are no red lines in these veins, but large viruses are also risk factors for bleeding, and these patients should be followed by esophageal gastroscopy each year. And for more rare disease, imaging methods may be used for diagnosis of primary sclerosing cholangitis. May be used ERCP, for example, endoscopic retrograde cholangiopancreatography. But this method is more cheap but invisible and partially invisible and not comfortable for patient. In this case, patient has to swallow this big tube, which you see in the picture, and under X-ray control, a doctor move this tube to the orifice of bile duct in the duodenum, to the papilla duodenum major, and when this tube connect with it, he press and to the button, and it leads to contrast introduction into the bile duct. In this picture, you can see that bile ducts are narrowed, arrows showed in these pipes, and above these narrowed bile ducts present some aneurysms of bile ducts. So in this case, passage of bile is disturbed, and bile stagnation in the liver present. It is abnormal situation. Liver doesn't look like when bile is stagnated inside of it. Liver can accumulate lot of bile, but it is not good situation for hepatocytes. It leads to hepatocyte damage and death. And more comfortable for patient but more expensive method is magnetic resonance cholangiopancreatography. It is near the same but not invasible. In case of MRI, we use contrast IV and patient and no need to swallow this big and uncomfortable tube and more sensitive method. In both cases, you see the same picture. Narrowing of bile duct and above this narrowing, dilation of bile duct and bile accumulation, pathological bile accumulation in the liver, which in time will lead to development of liver cirrhosis. And maybe the best method for the diagnosis, but invisible and not everywhere available method. But in case of good laboratory, uh, histological laboratory, I mean, when there are doctors who see many liver biopsies, in this case, this method is the best because we can see a real liver cells and what had happened in liver tissue. It is not always as obvious as in my pictures, but examples I present to you. In the left part, in the left picture, you can see steatohepatitis, and there are fatty cells inside the liver tissue. Fatty cells accumulation. If there are only few fatty cells, it's normal. It's not affect liver function. It doesn't lead to liver damage. But if there are a lot of fatty cells, it will lead to liver insufficiency. In case of autoimmune hepatitis, we can see accumulations of lymphocytes which produce antibodies, and mostly they accumulate around bile ducts. ACV liver biopsy in patients with chronic viral hepatitis C and chronic viral hepatitis B. In case of chronic viral hepatitis B, you can see so-called ground glass hepatocytes, which are typical feature of liver in case of hepatitis B viral infection. And most obvious changes with load of fibrotic area are in cirrhosis, in case of liver cirrhosis. Now let us have break for 5 minutes and then we list again all these methods and discuss about treatment in different liver disease. 5 minutes for break. Okay, break is over and we'll continue our lecture. There in the Russian Federation, there are standards for treatment and for diagnostic method for patients with different disease, which used in hospitals and also for outpatient. These standards not always include the most new method, which is not so commonly available, but mostly include methods which are commonly available in our country. I present you diagnostic methods for outpatients with hepatitis, obligatory diagnostic methods. Of course, complaints and anamnesis. And in anamnesis and complaints, I already told you, you shouldn't forget to ask about drugs which patient used and about toxins which he can use. Medical examination, which include, first of all, liver examination and examination of the signs of ascites and portal hypertension. Measurement of body mass and calculation of body mass index. And you see here included like obligatory examination, ultrasound of the liver, spleen, gallbladder, and pancreas for all patients with hepatitis. In analysis, we have to check protein, albumin, and albumin globulin in blood because in case of liver dysfunction, maybe hypoprotein and hyperalbuminemia. Bilirubin, total direct and indirect, and level of alanine aminotransferase, signs of cholestasis and damage of liver tissue. And signs of inflammation of the liver is not specific, and which includes CBC, erythrocyte, leukocyte, platelet, and ESR. More specific method, because very common are hepatitis C and hepatitis V viral infection, include HBS antigen, HBS antibody, HCV antibody. And if doctor, general practitioner, first of all are thinking about viral hepatitis, he have to send patient for consultation to infectious disease specialist. If still not clear for diagnosis, or if patient already has diagnosis, but general practitioner in polyclinic suspect development of complications, especially in patient with liver cirrhosis, he have to do additional diagnostic method. Esophageal gastroscopy. I already told you that according to recommendations, if progression of portal hypertension develops, it's very dangerous for bleeding, which can cause even sudden death. So esophageal gastroscopy is recommended to check presence of viruses in the esophagus, which always confirm diagnosis of liver cirrhosis, and to check risk of bleeding. Reticulocyte count is also helps us to see probability of bleeding, because if small bleeding present, for example in hemorrhoidal veins, it is bleeding is less significant than in the esophageal veins, but it can be chronic and can lead to chronic post-hemorrhagic anemia, in which will be high reticulocyte count. Globulin in blood, especially if we suspect autoimmune liver disease. Asparagine aminotransferase, prothrombinics, and fibrinogen if liver dysfunction is suspected. Glucose and amylase in blood, because very commonly liver disease accompanied by pancreas disease and chronic pancreatitis in many patients with chronic hepatitis also present. Urinalysis to see bile in urine, to see pigment, to see color of the urine. Also, cholesterol, gamma-glutamyl transferase, and alkaline phosphatase. Cholesterol destruction present in the liver. That's why hypercholesterolemia is typical for liver disease. And gamma-glutamyl transpeptidase, alkaline phosphatase, you will do in patient who develops jaundice and you suspect bile stagnation and in the liver. Bilirubin and urobilinogen in urine also in case of jaundice mostly. If previous serological tests for viruses are not sensitive, but you still are thinking about viral hepatitis, may be added ABC, antigen ABC antibodies, and ADV antibodies also. ECG can be done like additional method to check because liver disease leads to intoxication. Even fatty liver disease is a risk factors of heart problem, and heart problem may characterize by ischemia and arrhythmia development. Antinuclear antibodies and LE cells if you suspect autoimmune hepatitis. In this case, you have to do these antibodies. Now, more broad spectrum of antibodies can be used for diagnosis of different autoimmune disorders in patients with liver disease. We discussed about it. In case of cirrhosis, mostly the same diagnostic method, ultrasound of the liver, spleen, gallbladder, pancreas, and portal veins. Esophagogastroscopy, in this case, it's main method, not additional. Blood type and rhesus factor because this patient predisposed to bleeding and blood transfusion may be used like a method of treatment. CBC and reticulocyte at the same time with CBC, potassium, sodium, and iron in blood, cholesterol, urea, a lot of antigens, bilirubin, ALT, AST, gamma-glutamine transpeptidase, alkaline phosphatase, total protein, albumin, globulin, fibrinogen, urinalysis, and blood test in feces because can be bleeding in gastrointestinal tract from hemorrhoidal means and from esophageal means. No, near the same method like for hepatitis, but more broad spectrum. And in our recommendation, a liver biopsy with histological examination is gold standard in all guidelines for liver disease. It's most sensitive method, but it's strongly recommended only like additional diagnostic method in our country because this method it's not absolutely safe. Not everywhere present good histological laboratory, and it is invisible, and many patients don't want to do this method of investigation. Copper in blood, ceruloplasmin, it's for rare genetic disorders which lead to liver damage. Alpha-fetoprotein, coagulogram to check predisposition to bleeding, immunoglobulins in blood immune reaction, and in case of ascitic fluid analysis for differential diagnosis of different causes which can lead to ascitic fluid accumulation. And maybe consultation of different disease for diagnostic for making diagnosis and also to create plan for treatment. Indications for hospitalization. General practitioners have to know. Mostly, patient has this with liver problems, has chronic problems, and mostly he is observed by general practitioner or gastroenterologist in polyclinic. But sometimes these doctors have to send their patients in the hospital. Indications for hospitalization. Chronic viral hepatitis with moderate or high activity in the face of viral replication. If patients come to you with chronic viral hepatitis and tell that he has more weakness, you see subicteric sclera, small jaundice of the skin, or you give lab analysis and see that ALT and AST level is elevated. In this case, better to hospitalize patient for more clearly investigations and maybe for transformation of the treatment. Maybe treatment doesn't work properly and patient need more medicine. Another indication, chronic autoimmune or drug-induced hepatitis with high activity. Don't leave patient with moderate and high activity at home. Better to hospitalize them because high activity of liver disease means a high level of, first of all, high level of damage of the hepatocytes, which characterized by high level of ALT, AST, hyperbilirubinemia, and so on. It can progress very fast and may lead to acute liver failure, which can cause death. So better to hospitalize patients, don't leave them at home for prophylaxis of complications and disease progression. Chronic hepatitis, including alcoholic liver disease in stage of exacerbation. So it means steatohepatitis and alcoholic liver disease, which characterized by benign clinical cause, sometimes also can lead to exacerbation, which first of all characterized by cytolytic syndrome and mesenchymal inflammatory syndrome, high ASR level, high C-reactive protein, ALT, AST, and so on. So in these cases, better to hospitalize patients. First of all, patient with viral hepatitis, autoimmune hepatitis, patient with primary biliary cholangitis and other disease, and also you shouldn't think that benign liver disease like alcoholic liver disease and fatty liver disease always absolutely benign. If exacerbation, you have to hospitalize patient. All these indications are for patients with hepatitis. What about cirrhosis? Cirrhosis is more severe stage of liver disease, but in this case, more difficult to change something in the clinic. If liver cirrhosis is not diagnosed before, of course, you have to hospitalize patient for proper diagnostic manipulation to prove this diagnosis. But if diagnosis already present, only decompensation of liver cirrhosis is indication for hospitalization. Because if liver cirrhosis is not decompensated, patient know how to treat, which medicine to use, and this disease is long-lasting disease. Patient is ill and he is not able to work, but it is long-lasting situation. Fortunately, in many patients, it doesn't lead to fast progression and sudden death. That's why mostly these patients without decompensation are observed in outpatient conditions. Treatment. Now, first of all, you shouldn't forget about non-pharmacological treatment. Good physical fitness program may lessen distress symptoms. Uh, Patient shouldn't have sedentary lifestyle, even if he has severe liver disease. He have move as much as possible, as much as it's comfortable for him, because movement improve bile passage, it's improve liver function. So patient shouldn't sit or lie all the time. If he may move, he have to move. He shouldn't be sportsman, but he have to do exercise. Diet should be well balanced. Patients should be advised to limit the amount of salt if patient has portal hypertension and if patient suffer from liver cirrhosis. Uh, because it's prevent accumulation of fluid in ascitic fluid or fluid of in the ankle which lead to ankle swelling. Also, if you know what leads to liver damage, you have to advise patient to stop usage of these etiologic factors. For example, cessation of causative drugs uh, and management of complications also is important treatment of ascites. But cessation of positive drug, alcohol cessation, decrease calorie in the diet in different situations may be very helpful. In fatty liver disease, obesity, if patient became less obese, it will lead to prophylaxis of progression and even improvement of liver function. If patient may stop alcohol abuse, he may develop transformation of significant liver change to normal situation and so on. Now, other types of treatment. It's hepatoprotectors. It is something intermediate between drugs and non-drug treatment because no trials which proved its effectiveness except few of them. But patient loves these drugs. They are not harmful. Maybe they have protective mechanisms and it can be divided to two groups, animals and plants. Animals, for example, hepatasan, prohepar, seripar, very famous drugs. Plants includes carasil, hepabene, legalon, hafitol, tuquiol, and other hepatoprotectors. Also, vitamins from group B and group E and vitamin E. Both of them are recommended commonly to patients with chronic liver disease and may be used in clinic. Not all the time patients use hepatoprotectors and vitamins, but clinical course, which include 1-2 months, patient as a rule loves this clinical course of hepatoprotectors and follow doctor's recommendation. It's usually not improve patient condition too much, but maybe it stop disease progression. So you have to use this group of drugs. Also, hepatoprotectors include amino acids, which are adimethionine and ornithine. This one is more powerful hepatoprotector. And also in class of hepatoprotectors include ursodeoxycholic acid. This one is most effective drug from all listed before and which you can see after. For example, essential phospholipids essentially and inhibitors of lipid peroxidation ionic acid. So ursodeoxycholic acid is proved in big trials that it decreases inflammation process in the liver, that it decreases fibrin formation in the liver, and also it helps to evacuate bile outside of the liver. This drug is really good and recommended very commonly in patients with chronic liver disease. Unfortunately, very commonly it has side effect, and it can lead in many patients to significant diarrhea, to some discomfort, abdominal discomfort. That's why not all patients may use it. But nowadays, this drug from hepatoprotector is the most proof and most powerful. Now, treatment, if you know etiology or pathogenesis of hepatitis, you have to use different groups of drugs. For example, if it is autoimmune hepatitis, you have to use immunosuppressive therapy. corticosteroid prednisolone, or cytostatic azathioprine. In case of exacerbation, prednisolone is first-line treatment. If patient has no exacerbation, if chronic autoimmune hepatitis persists without exacerbation, better to use azathioprine because it has immunosuppressive activity but less side effect compared with prednisolone. Now, in case of alcoholic hepatitis, stop alcohol consumption, high quality diet with high protein concentration. But it is very difficult to stop alcohol consumption because patients' metabolism in persons who use alcohol regularly change it, and the metabolism of alcohol is more easier for our organism. And patients cannot switch completely as a rule this metabolism to normal feeding. In case of cholestasis, ursodeoxycholic acid and yes, well, you already discussed it in hepatoprotectors, and I told you that it helps except decrease inflammation, it decrease cholestasis. So ursodeoxycholic acid or obeticholic or acid. In case of itching, in patients with cholestasis, cholestyramine and rifampicin. And about vitamins, we already spoke. For viral hepatitis, there are a few groups of drugs which commonly used. It is interferon, pegylated interferon, nucleoside analogs, and more new group of drugs which call direct-acting antiviral drugs. Direct-acting antiviral drugs are sofosbuvir, cimeprevir, dasabuvir, ombitazvir, paritaprevir, tenofovir. It's not our task for today to speak about viral hepatitis, acute and chronic. So I only mentioned few special groups of drugs which are effective antiviral in case of chronic hepatitis. If chronic hepatitis transforms to cirrhosis, one of the main problems is ascites. And ascites treatment includes diet, include enough calories and proteins, and moderate restriction of sodium intakes, around 5 grams of salt per day. This is generally equivalent to a no added salt diet with avoidance of pre-prepared meals. Because no need to add salt, because salt already present, for example, in bread, in sausage, and this salt is enough for patient with ascites. No need to add something more. Prolonged bed rest cannot be recommended because there is insufficient evidence that it is beneficial in the treatment of ascites. Better if patients do mild movement, do mild exercise. Ascites is fluid accumulation. You have to use diuretic. Start with potassium spironolactone. If no effect, or in patient with long-standing or recurrent ascites, you should add loop diuretic, furosemide. And you shouldn't make forced diuretic. Maximum weight loss have to be 0.5 kilogram per day in patient without edema. Paracentesis is the first-line therapy in patient with large ascites, grade 3 ascites, which picture I showed you before, which should be completely removed in a single session. Even large ascites should be completely removed in single session. Albumin, 8 grams to each 1 liter of fluid removed during paracentesis. Because during paracentesis, you remove not only water, you remove proteins. And to increase oncotic pressure should be used albumin IV. What is it paracentesis? A picture. It's puncture of the abdominal wall with big syringe and evacuation, slowly evacuation of fluid from the abdominal cavity. Another significant problem in case of ascites and portal hypertension is esophageal bleeding. A restrictive transfusion strategy is recommended in most patients with a hemoglobin threshold for transfusion of 70 gram per liter and a target rate of 70 to 90 gram per liter. I told you that we have to check which group of blood this patient has for transfusion. If large bleeding, patient needs blood transfusion. Antibiotic prophylaxis is recommended in cirrhotic patients with acute gastrointestinal bleeding because it reduces the incidence of infections and improves control of bleeding and survival. Usually ceftriaxone or norfloxacin. Bleeding is in the abdominal cavity, and if there is a lot of blood in the abdominal cavity, there are our bacteria of in the intestinum love this blood, and it grows, start grows, and this growth is uncontrolled. That's why to decrease this uncontrolled growth of pathological bacteria, we have to use ceftriaxone or norfloxacin. Vasoactive drug therapy should be initiated as soon as acute varicose bleeding is suspected and before endoscopy. Terlipressin, somatostatin, or creatine are accepted options. So if present bleeding, have to be blood transfusion, antibiotic for prophylaxis, and for constriction of veins, you may use such drugs like terlipressin, somatostatin, or creatine. And more uh, helpful is endoscopic treatment, endoscopic ligation in case of esophageal bleeding. When acute varicose bleeding is confirmed by endoscopy, ligation should be performed within the same procedure. So endoscopy have to be done in all patients with esophageal bleeding. Up to 10-15% of patients have persistent bleeding or early rebleeding despite treatment with vasoactive drug plus varicose ligation and prophylactic antibiotics. Transjugular intrahepatic portosystemic shunt should be used as the rescue therapy of choice in such cases. No, it's only for your knowledge. It should be done in the hospital. If emergency conditions develops in the polyclinic and patient come to you with bleeding, you have to hospitalize him as soon as possible for endoscopic ligation and for treatment in emergency care unit. What is it as a esophageal varices ligation? Endoscopes, varices, and ligation of the varices, which are sources of bleeding. Stop bleeding due to ligation. Other treatment of cirrhosis include uh, decrease inflammatory stage, maybe use statins. They are helpful in case of cirrhosis due to hypercholesterolemia. And also statins have anti-inflammatory properties, so can be used in patients with liver cirrhosis. To reduce portal hypertension, you have to use beta blockers. These drugs can be used and for in patients with chronic liver disease. They are helpful in patients with cardiovascular disease and very common combination of both these diseases. You shouldn't forget about these drugs, statins and beta blockers which are helpful for both cases. And even in patients with isolated liver disease and liver cirrhosis, you have commonly recommended statins and beta blockers. They are not harmful. And beta blocker, first of all, it is old beta blocker, anaprylin, which is helpful to reduce portal hypertension. Now, for eating and for pruritus, you can use ursodeoxycholic acid. I mentioned previously that may be symptoms of hypogonadism in men. In this case, you may recommend testosterone preparation. If present significant encephalopathy, in outpatient, you have to hospitalize this person. If encephalopathy is non-significant, you have to recommend in diet a restriction of proteins and also sanitization of intestine. If present constipation, it leads to accumulation of pathological molecules which affect the brain and lead to encephalopathy progression. So lactulose and cleansing enemas may be helpful in a treatment of encephalopathy. Also, overgrowth of some bacteria can use to intoxication. Rifaximin or vancomycin in this case may be helpful. No, all other method of treatment can be used only in the hospital. Fresh frozen serum, gastric lavage, L-arnitin, L-aspartate, albuminous dialysis, and other IV solutions used in the hospitals. The same for spontaneous bacterial peritonitis, which can be a complication in case of portal hypertension and ascites. Mostly we use to treat these complications different group of antibiotics. But this complication is treated only in the hospital. You have to hospitalize if you are outpatient doctor. What include standards in treatment of cirrhosis? You have to remember that we are speaking about not decompensated cirrhosis in situation with stable patient because very commonly affected pancreas together with liver in case of cirrhosis, some pancreatic enzyme. Sodium and protein restriction, diuretics, spironolactone plus furosemide, anti-constipation drug, lactulose, and antibiotics, like we discussed above. Indication for hospital, more severe situation, class C, liver cirrhosis is indication for hospitalization and liver transplantation. Liver transplantation is a potential medical option given in the most cases of end-stage liver disease. But it is not procedure which may be done in outpatient. That's why general practitioners have to know different clinical score for assessment of severity of liver cirrhosis to send patient for liver transplantation in time. One of the most important clinical score is Child-Pugh score, which includes calculation of total bilirubin level, serum albumin, international normalization ratio, ascites, and hepatic encephalopathy level. All of them are transformed by score. All these scores make sum of all this score, and based on it, we classify cirrhosis to three classes. Class A, if sum is 5, 6 points. Class B, 7, 9 points. And Class C, 10, 15 points. Class C, more severe situation. More than half of patients will die during 1 year if will not be done liver transplantation. So these patients should be hospitalized, and if it is possible, they have underwent liver transplantation. Class A has 100% yes, survival. So they shouldn't be hospitalized, and liver transplantation is not indicated for them. Class B under question depend on etiology, accompanied disease, and many other specific situations in each person. What is liver transplantation? And for us, for uh, doctors in the polyclinic, more important also management of outpatient after liver transplantation. You have to make consultation of this person with many specialists who underwent liver transplantation, because maybe many complications after this procedure, and to prevent it, uh, you have to find it, and general practitioner cannot see this complication, so you have all these complications in time, so you have to send this patient to many specialists and do a lot of analysis. All this analysis we already discussed, which includes bilirubin level, fibrinogen, prothrombin, immunoglobulins, CBC, and so on. We already talked about this analysis. Esophageal gastroscopy, ultrasound examination, X-ray and ECG also should be done in patient after liver transplantation. What about prophylaxis of liver disease? The diet for normal BMI, regular physical exercise. Patients with chronic liver disease should receive vaccination to protect them against hepatitis A. Other protective measures include vaccination against hepatitis B, pneumococci, and influenza. All newborns should be vaccinated against hepatitis B. 3 injections are needed to provide adequate immunity. So prophylaxis is normal lifestyle, diet, and regular uh, exercise, and also antiviral vaccination. Disability. This examination of temporal disability is a type of medical examination, the main purpose of which is to assess the patient's health status, the possibility of professional activity, the level and terms of the temporal disability, and in some cases, the prognosis for future work capacity. Duration of temporal disability depends on clinical cause of the disease, social condition, professional re-equipment, and other factors. And average terms of temporary disability in patients with chronic liver disease. These terms are average and depends on patient's condition in each situation. In alcoholic hepatitis, sick leave may last average duration around 1 month. In alcoholic cirrhosis, 1 month or 1.5 months. Chronic persistent hepatitis, 1 month. Chronic active hepatitis, 1.5 months. Biliary liver cirrhosis, 2-3 months. And some of them need medical social expertise for chronic disability. Patients with chronic hepatitis shouldn't work at night time and have a lot of travel. They couldn't work with toxic agents and chemicals. exacerbation of chronic hepatitis, list of disability lasts up to 13 days, sometimes to 14 days. Attending physician gives to outpatient medical certificate for temporary disability which lasts not longer than 15 days. If outpatients need more long medical certificate, he must visit health authorities. In case of unfavorable prognosis for the work, medical commission during fourth month send a patient to medical social expertise for fixing the group of permanent invalidity. Patients with chronic hepatitis and significant changes of liver functional activity and complications are directed to medical social expertise. Liver cirrhosis is common reason for chronic disability. Liver cirrhosis accompanied by hepatosplenomegaly and severe portal hypertension is indication for chronic disability without re-examination, which have been set within 2 years. So, hepatitis mostly for sick leave, and sick leave duration around 1 month or 1 month and a half. Uh, Liver cirrhosis, you have to send to medical social expertise because this patient is chronically ill, disease is very severe, and patient is unable to work for a long period of time. Follow-up of patient with chronic hepatitis and cirrhosis carry out general practitioner, hepatologist, infectious disease specialist. Depends on the origin of the disease. ALT and other liver enzymes are taken once in 1, 3, 6, or 12 months depending on hepatitis activity. Additional diagnostic method is necessary. Patients with chronic hepatitis B or C in Crimea are examined and treated on the basis of order number 616 from 270416. So, patient have to visit polyclinic and is managed by general practitioner, hepatologist, and in case of viral hepatitis, infectious disease specialist. Most available method of control of activity is LT examination. Ultrasound and endoscopy can be done if it is necessary. Thank you for your attention. The lecture is over. Goodbye.